I'm going to talk today about something that I hope will be a little bit entertaining, because I know you've been sitting listening to talks. This is a surgical talk about transplantation of an organ that may in the future be something that is not needed. In fact, the progression of this disease, both inflammatory bowel disease and liver disease, may be going to be altered quite significantly by the work we've just heard from Professor Holtman and that very entertaining and interesting talk. But I'm going to continue today to talk about something at the moment that's still the mainstay of therapy for PSC patients who do develop end-stage complications, and that's particularly of the liver that you can see here. And the liver is the organ that really bears the brunt of the inflammatory response, and the end result of that is liver failure and all the problems that go with it. So despite everything, liver transplantation remains an extraordinary treatment for this condition. So I just thought a little bit of a history. This is a picture of the very first renal transplant successfully done in 1954 in Boston. And that man in the middle, Joseph Murray, won a Nobel Prize for this. And these were a transplant of kidneys between two identical twins. That's Joseph Murray over here. 1954, and transplantation really was in its infancy, but nobody was going to get a liver transplant or a kidney transplant in 1954. And in fact, it wasn't really until the 1970s that transplantation started to become increasingly available. And the man that really probably should have won a Nobel Prize is this man. He's the man that Tom Starzl, originally based in Denver and then Pittsburgh, and pioneering surgeon, extraordinary man who developed renal transplantation and took it from identical twins to being available to everybody, and really doubled the world's experience when he presented data in about the mid-1960s. And at the same time in the 1960s, he was working on liver transplantation. So it's really quite extraordinary that the development of liver transplantation was occurring at a time when even renal transplantation was not widely accepted. And this is a picture of a very well-known transplant surgeon, Carl Groth, and the three original surviving children, the very first children in the world. This pediatric transplantation was liver transplantation was pediatric transplantation. And you might ask, how on earth could you start transplantation in small children? And the answer was that these small children were all going to die of underlying liver disease. And Tom Starzl's endeavor was to do something to save their lives. And this is the first three children who ever survived. And in the 1970s and 80s, the survival at 1 year was about 25%. So these are the first three surviving children ever in liver transplantation. And in the 1970s, survival rate remained extraordinarily low, something of the order of 25%. And it was really the introduction of these new outstanding drugs, cyclosporin 79 and tacrolimus in around about 1990, that really allowed the results to improve. So the history of transplantation of the liver really didn't take off until really about 1984-85, having received approval by the NIH in the United States. So it's still a relatively recent procedure. And it's still a very simplistic procedure. It basically involves three stages. You remove the old liver, and you have a period of time where you actually have no liver, and then you implant a new liver. And that's the essential components of the three stages of liver transplantation. Lots of things to sew in together. You may need to graft and adjust the plumbing, and ultimately correct the bile duct, or rejoin the bile duct, which of course is the major issue in PSC. There's complex arteries and lots of sort of simple plumbing. And the high-tech part of this is that it's all done just with suturing and microscopes or magnifying glasses. And liver transplantation is a little more complex because we can combine liver transplant with other multiple organs. You can have a heart, a lung, and a liver. You can have a heart and a liver. And this one is quite common, where we have a liver and a kidney. Because one of the problems and complications of end-stage liver disease is, in fact, renal failure. And a small group of these patients really aren't going to have their kidneys recover. So we combine a liver transplant and a kidney transplant. So we have to look at all of these parameters in our recipients, and that includes the PSC patients. You need a very big team, and I've always liked this photograph because it just shows lots of hands operating on the liver on the back table. This liver has been removed from a patient who's died and is now being prepared for implantation. It's a big operation. It takes 8 to 10 hours at least, if not longer. And there are a minimum of 8 to 10 people in the operating room at any one time. And I've always liked this photograph, which was actually of an artist who actually has having this transplant. It was a photograph of his transplant, and he subsequently painted a picture of the photograph of all the people who were actually, or some of the people who were attending his transplant operation. And this, again, just sort of highlights the technology that goes. It's an operation that can involve extensive blood loss. In fact, one of the huge contributions that liver transplantation has made to surgery is the management of massive blood loss. And the technicians here are very much under control. All these machines are removing blood, washing it, processing it, and being able to return it. And we have our technician here who's very relaxed. In fact, he's so relaxed, he's reading a magazine, which I assume was not a magazine with the instructions of how to run the program. The team of the transplant is very much bigger than the actual operation. So you need all of these services surrounding transplantation: cardiac, pathology, anesthesia, infectious diseases, ICU, renal medicine, of course, nursing, allied health, and of course, the donation services. All of this is centered and focused on getting a patient, PSC patient or otherwise, who has end-stage liver disease through the transplant. And the other big issue is that this service has to be available 24 hours a day, 7 days a week. It's totally dependent on organ donation, and organ donation is dependent on somebody dying and volunteering to donate an organ. It's unpredictable, and it's only acceptable if we can provide this service when the organs are available. And this service is extraordinary in that it has to be available completely throughout the entire year. It involves multiple shifts of anesthesia. You might be running 12, 14, 2 or 3 shifts of nurses and anesthetists, technicians. And that in itself is an organizational tour de force for the institutions that do this. Now, PSC, you will all know a lot about PSC, cholestatic liver disease. And the reason I'm touching on this is very relevant to transplantation. If you're going to transplant a patient who has PSC, you have to have an understanding of the disease and current therapies and management. It's an obliterative fibrosis of the bile ducts, and this fibrosis affects both the intrahepatic bile ducts and the extrahepatic bile ducts. And of course, the association with inflammatory bowel disease is very relevant. It doesn't become apparent usually until after the age of 30. And what we do know is that progress of this liver disease is not overly predictable. So management of the patients consists of observation, and really close observation ongoing. And the progression of the disease can vary and alter. So it makes up at the moment probably 10 or so % of the patients that we have transplanted in our own unit, but here in Australia. So PSC is a relatively, as Professor Holtman said, it's a rare condition, currently 5th or so most common indication for transplantation. But what we do know that progressive liver damage is progressive in a significant number of patients. And the end result is going from a normal liver to this scarred cirrhotic liver. And this is the liver where the little bumps that you can see in the liver are bits of liver trying to regenerate. And the pale white bits in between are the scarring and fibrosis that are never going to be able to regenerate. And I think Professor Holtman touched on this, that once you get a certain degree of liver damage, you're never going to be able to resurrect or correct this, and the liver is going to be unable to regenerate. And the other diseases that affect the decision for transplant is the ulcerative colitis, the inflammatory bowel component, the age of the patient, presence of underlying Crohn's disease or mixed connective tissue inflammatory disease, and the overall demographics and history, trying to work out the progression in any individual patient. And all of this will help with the decision as to whether a transplant is needed. So it's not a black and white decision, and it's often a very difficult decision to make. And there are patterns of PSC within the liver. You can get the classic, which is very small duct, the tiny microscopic ducts way out here. We can't even see them. And then you get the slightly larger ducts. You can see the stenoses and inflammatory narrowing. And then you get the more central narrowing. And then you can get the main bile duct affected. And here you can see some stricturing and narrowing. And sometimes the disease varies in its intensity in between the outside the liver and both inside the liver. And of course, if this part of the bile duct's involved, you're going to have to chop that out and replace it and reconstruct it. And that's going to affect the operation that you need. So the natural history of patients that we see who are heading towards a transplant often involve infection within the bile ducts. And this is partly related to stones and debris that obstruct the bile duct and allow bacteria to proliferate and grow, largely through obstruction. These little blockages up here in these bile ducts, the bile stagnates and bacteria can grow. So cholangitis, infection, fever, and temperature are really a significant change and an indication for transplantation. Strictures themselves can be treated, but only if they're really central. Once you've got small duct strictures or they're out in the periphery, these cannot be treated by dilating or stenting. And cirrhosis of the liver, of course, is the inflammatory condition that results in destruction of the liver cells and all the problems that go with not having enough liver. And another big problem is the portal hypertension, which I'll touch on. And the symptoms of end-stage disease are not just the liver. It's rather interesting. And overall, the disease progression, liver disease and IBD, is variable, and it's not always linear. And someone can be going along quite stably and suddenly fall off the edge quite quickly. So what about the liver? Well, it's the biggest organ in the body, and the extraordinary thing about it, and I love taking medical students through this, when your liver fails, just about everything else falls apart. The liver is a highly complex and sophisticated organ. And when you get liver failure, you get brain failure, lung failure, heart failure, kidney failure, intestinal failure. Your bones are dramatically affected. Your muscles are affected. You get tremendous muscle wasting, and your immune system's affected. You're prone to get septic events. And the end result of all that is tiredness, lack of stamina, loss of appetite, muscle loss, abdominal distension from fluid retention, bruising, jaundice and itching, very easily detectable in the eye once it gets to be about double normal. You can get lung failure. So the patient actually might be presenting with shortness of breath and breathing problems. Fever and rigors I touched on, very common. If it occurs occasionally, it's manageable, but each of these events triggers more damage to the liver, and at some point this becomes a major problem. And recurrent biliary infections related to this are a major indication, and ongoing pain and trouble. And the other thing that I haven't mentioned here is, of course, the risk of developing malignancy, which I'll touch on in a minute, or a cancer. So how do we follow? Well, Professor Holtman mentioned this in his study. The great majority of patients who have PSC of any significance will have abnormal liver blood tests. It's quoted at 60 to 70%, but it's probably pretty close to 100%. If you have significant liver involvement, you'll have abnormal liver tests. And there are lots of different liver tests. They're called function tests, but they're really more just static markers of ongoing liver damage. But we will see these enzymes elevated. We'll see anemia from blood loss. We'll see bilirubin is elevated if we measure it. The platelet count goes down and the inflammatory markers are up. And you can see abnormal clotting. You can see a patient, PSC patient, who's been followed here, and you can just see the clotting starting to deteriorate. It should be running around 1, but we can see gradually here over several months the clotting deteriorate. At this point, the patient was transplanted. And we can see the bilirubin here, which should be 20, starting out at 100 when a patient was referred, and then continuing to drift off. There's a log scale, so it's now about 500 or 600. And these tests are very useful in monitoring the progression of the liver disease. And one of the really big problems is portal hypertension. The entire blood flow of your intestine, everywhere from the top to the bottom of your gut, goes straight to the liver. And if it can't get through the liver because the liver is scarred, the pressure in these veins rise and the blood has to find some way to get back. And it opens up all these little channels that head through various other places. And the high risk ones are these channels that open up around the stomach and the gullet and esophagus. And these, you can see the varicose veins here. They're a bit like varicose veins on the legs. And these are very prone to rupture and can cause life-threatening bleeding. So monitoring portal hypertension is often done with scopes and looking at these varices and actually treating these to prevent subsequent bleeding. And I touched on before breathing. This is a picture of a young male with marked abnormality of his fingers. And this is due to the fact that he has a blood oxygen level that's equivalent to him living at the top of Mount Everest. It's running about an oxygen level of 50. So his liver was failing, but he needed a liver transplant because his liver failure was causing lung failure. And the lung failure was what was serious and was going to kill him. And he got transplanted here, and just almost dramatically, within 2 or 3 months, his oxygen improved dramatically, and the shunting of blood through his lungs dropped dramatically. So the indication for transplantation when you have PSC and liver disease is often very difficult. And the big question we have when a patient is referred is, does this particular patient really need a liver transplant? And if they do they need it right at this moment? And the reason we're not jumping into doing transplants, because it's a balance of risk. The transplant itself has a certain amount of risk that goes with it. And we have to know that the risk of that liver staying there by itself outweighs the risk of the actual transplant. And this risk to the patients based on quality of life. And there are patients who say, look, this is just, my quality of life is just so atrocious, I can't go on. The severity of those symptoms, recurrent infections, and the underlying seriousness of the liver disease, where we can kind of predict that this is really getting to be end stage. And the other thing we have to factor in the other risks to life that maybe are there if we leave that liver in situ. And one of those risks is the development of cancer within the liver. So the patient's liver may be okay, but we may have certain indicators that imply the risk of malignancy, and that's going to become the dramatic feature that forces us to consider transplantation. What about previous surgery? Well, a heck of a lot of patients with PSC have had previous surgery. They've had their gallbladder removed, they may have colon surgery, may have had a more complex pouch surgery, they may have had bile duct stenting, variously complicated, percutaneous drains, metal stents. And the really good news is that none of this really interferes with the liver transplant, because luckily it's all well below the liver, and most of the surgery we're going to do with the transplant's right at the top of the tummy, and this stuff's somewhere else. But it does influence our decisions, and it does modify a little bit about what we do. And we certainly need to know about all this before we tackle a transplant. So what happens? Well, you get referred for workup to one of the liver transplants units. There are 5 units: Auckland, Brisbane, New South Wales, Vic, South Australia, and WA. We all work together and we all practice very similarly. And if you get referred to any one unit, you're going to probably have very similar recommendations and treatment. And you'll be under the initial care of a specialist liver transplant hepatologist. That'll be Professor Holtman, who has an interest in transplantation and has a feel for when this disease is starting to cause major problems. And do you need a liver transplant? We assess the severity of the disease. We want to assess the trajectory and progression of the disease. What's going to happen? If you don't need one right now, what do we think is going to happen over the next 12 months, 2 years? And that's going to be based on the symptoms, the location of the bile ducts and their damage, the potential risk of cancer. And we want to think about the other risks. Is the heart involved being affected? Are the kidneys being affected? Are you losing muscle mass and sarcopenia? Because this in itself is an enormous risk to survival. Or are you having recurrent infections that are causing problems? You get an extensive workup. What's your liver like? For example, just looking at the CT scan, this is a scan looking at the liver. This is the heart here, the feet are at the bottom. And you can see this liver is a knobbly, tiny, it should fill this space here. And you can, very severely scarred and cirrhotic. You can see the spleen is enormously dilated due to the fact of the portal hypertension and the blood not able to return. So just looking at that liver, we could say without any other test, this is end-stage liver disease. And even though this patient might be coping okay, he will have 0 liver reserve, he or she, and very little backup, and could easily, within a matter of weeks, be in ICU in big trouble. And I mentioned heart involvement. So one of the things we want to monitor is cardiac progression and cardiac function. And we have some wonderful tools. This is a cardiac ultrasound called a DSE that enables us to look at functional studies of the heart and actually look at how it's working. And we can monitor that performance over time. And that might be an indication that we should do something about transplantation, not the liver itself. So you're activated for liver transplantation. What happens then? Well, you go home and wait. You remain under your current treatment. And remember that the majority of patients with a liver transplant is going to be dependent on organ donation. And that's going to be dependent on the degree of your sickness and where you look on where you sit on the list. So if you're very sick, you'll go to the top of the list. So you could present on Monday and go to the top of the list on Tuesday. And this means that somebody like that is going to leap ahead of someone who may have been on the waiting list for many months. And that waiting time is going to depend on your blood group, because the blood groups do vary and affect the actual outcome. For example, if I had a choice of what blood group I was and I needed a transplant, I'd choose blood group A because they tend to have a shorter waiting time because there are fewer people and we seem to have more donors. It depends on the size of the liver. If you're tiny, you can't have a great big donor liver. The other problem is that PSC patients on the whole tend to be relatively stable over a long period of time. And doctors can see them and think, oh, well, Jim is, he's been like that. I saw him a year ago. He's fine. He can come back in a year. And the progression is so gradual that it can be missed. And that means that patients with PSC can sit on that waiting list for quite some time, being bounced by someone who turns up in a sicker state. And so we have to be very aware of that and be very aware of our individual patients and be able to monitor them closely. So we touched on the risk of cancer. We know that inflammatory conditions are cancer risk, and this is particularly so, as Professor Holtman touched on, in the gut itself, particularly the colon, but also within the liver. These bile ducts are very prone to damage, and ongoing inflammatory damage causes bile duct cancer. The cancer is small, minor. These ducts are tiny. They're literally the size that you can see here. And you can imagine a cancer that's occurring in these ducts, you can almost not see it. In fact, we can only determine there's a cancer here by the fact that there's nothing here. We can see the bile duct here. We can see the gallbladder draining here. We can see ducts here, and then they suddenly stop. And they're stopping because there's a cancer squishing and blocking this bile duct, and we're unable to actually see the ductal structures. Now, we don't know that's a cancer, but we'd be very, very suspicious. And if we saw that, we'd be very nervous about what was happening. And hopefully, of course, we would have picked this up way before that happened. And how do you gauge sickness? Well, you don't need to have too many measurements to have a look at a patient like this who is extraordinarily sick. This is post-transplantation. And sometimes, though, it's not that easy to determine. So we have a scoring system which takes away the sort of arbitrary classification of, I think this patient's sicker than that patient. And our scoring system is based on numbers, which you can't really alter. And it ranges from sort of 14 to 40 or so. And if you're 40, you haven't got long to live. Then what we know is that once your scoring of these things hits 14, you probably should be thinking about a liver transplant. And this is a MELD score in a patient who's ambling along at two different ways of measuring it, but he's running along at about 15, 20. So he sort of needs a transplant and starts to deteriorate here and then gets transplanted around about here. And this is another patient, MELD score starting to get pretty high, 25, gets transplanted and MELD score normalizing. So these are scores that are very useful. Now, this is some of our own data. In the last 25 years, we've had 345 referrals of patients with PSC, roughly 2 to 1, slightly not quite that, 1.8 males to 2 males to just about every female. And we've transplanted about half of these patients, 168. So the other half we're sitting on, watching, waiting, and they haven't needed a transplant. And you can see that the transplants tend to be higher in the younger group of patients. Once we're getting up to here, patients who are aged 36 to sort of 65 where this disease is commonly. Patients have had this disease for 15 years, their liver's severely affected, and this is when they present for transplantation. And about half of these patients who present are ending up being transplanted. Even a small number of older patients are being transplanted, up to the age of almost 75. So we really have no real age restriction. And the restriction is really based on whether we think you can survive a transplant. And this is the overall data in Australia for children and adults who've been transplanted. And it's based on age groups, and it does vary depending on how old you are. Not so much for children, but particularly for adults. And if we look at the survival by disease in Australia, this is a 30, 35-year survival. We can see that PSC is right in the middle, and it actually doesn't affect the outcome compared with other diseases. So if you have PSC and you need a transplant, you're going to do just as well as anyone else who has any other significant liver disease. But what can affect the transplant is the type of transplant you have, and I'll touch on that. So we can give a whole liver or part of a liver or bits of a liver or reduced livers, and these are not necessarily as safe as getting a whole really good liver. So we have to bear that in mind, and I'll touch on that when we come to transplantation. You'll have lots of follow-up after. You're really going to be swapping one disease for another. You're going to swap end-stage liver disease due to PSC for liver transplant disease. And we will need to keep you under observation for life. You're going to need these powerful immunosuppressants. And this is the drug cyclosporin, discovered from this fungus from a soil sample in Norway. And cyclosporin regarded all their staff as potential sources of drugs. And when you went on holiday with Sandoz in the 1970s, you had to collect little soil samples, and they gave you little pots of stuff, and you had to bring them back to Sandoz. And Sandoz grew those to see what fungus was in them, and then they looked at these funguses to see what they were making. And this was a soil sample brought back from Norway by one of their candidates. And John Burrell found this fungus, and it produced this drug called cyclosporin that turned out to be a really poor cancer drug, but just had unbelievable immunosuppressive qualities. And this drug revolutionized transplantation and resulted in the saving of multiple lives, both kidney, lip, every form of transplantation. And the management of this disease, of this drug, is difficult because these are individual patients, and you can see the absorption of this drug varies tremendously. This patient absorbed it fantastically. These patients hardly absorbed it at all. So monitoring these drugs became really, really important. And it's a really tight band, which is why drug taking and reliability and consistency are very important if you have a transplant. Because you happen to be down the bottom here and not absorbing your drug, you're very much more likely to end up with rejection. And after transplantation, we watch you for all these sorts of problems. And interestingly, recurrent disease can be a real problem, and I'll touch on that with PSC. But the big problem are these drugs themselves. These drugs cause problems. They cause bone disease, metabolic disease, kidney failure. So the drugs themselves, it's sort of a catch-22. You have to have these drugs to save your life for a transplant, but the drugs themselves go on to cause problems. And there's a lot of work trying to minimize this risk after the transplant. So recurrent transplantation, when I started, we didn't think it occurred. This is PSC, you had a new liver, it didn't occur. The new liver was, of course, totally not matched. Nobody was going to get a living-related liver transplant. So the liver donor was not the slightest bit same as you, and we felt that that would protect you from getting recurrent PSC. But over a decade or 20 years, we realized that PSC did recur in about 25% of patients. This is European and North American data, but we think it's the same here. And it typically occurs again 6 to 7 years after your liver transplant. And that would fit again with Professor Holtman's theories and work on gut flora and the effect of gut flora. So this again might be something that we can manage effectively post-transplantation. Or maybe vancomycin is going to stop you developing liver disease. It's something that we really need to look at. What we do know is that ongoing systemic inflammation increases the risk of recurrent PSC, and that includes inflammatory bowel disease. And there's a lot of debate about whether having a colectomy, so getting rid of the inflammatory bowel part, does that actually reduce recurrent PSC? And there's a fair bit of data suggesting that that might be beneficial, but there's also a little bit of data suggesting that it probably isn't beneficial. And it may be now that vancomycin might be the source of treatment for patients who still have a colon. But what you do need is ongoing observation if your colon's still there. Now, a little bit about organ donation, because we still depend totally on an organ donor to do this. The majority of organ donors in Australia are brain-dead donors, donors who have died in ICU, their heart is beating, they're pink, but their brain is completely dead and they have no chance of recovery. The second form of donor is a donor who is going to die, but whose brain has not officially died. And these are cardiac death. You have to wait till the heart has stopped before the organs can be retrieved. And a significant number of our donors are now these donors. And that's got some implications because these donors take an extra hit, and the liver doesn't like being removed after waiting around for the heart to stop. And these patients can end up with more bile duct problems. And this is a patient who's had PSC who immediately is developing PSCF. But there are a lot of DCD donors, and we need to look at these as potential donors, even for PSC patients. And the last form of donor is a living donor. You turn up with your brother or a cousin. Why could they not be a donor? Well, there was an initial feeling that if you had a close relative, they're going to share possibly some genetic makeup with you, and the risk of recurrent PSC would be higher. But interestingly, it doesn't seem to be that way. So living donation probably is a potential option for some patients, particularly children who have end-stage liver disease. But I'll touch on why we're not enthusiastic about that. So normal liver is warm, perfused, the heart is stopped, and very rapidly it gets perfused and it's cold. And this is just a matter of minutes. So the liver is rapidly cooled from being warm. Within minutes, it's cold, goes down to about 4 degrees, and then it can sit in the esky for many hours before it's warmed up and stuck back into the patient. So that's our liver donation from someone who's died of brain death. But if you have a cardiac death, or you have to withdraw treatment in your patient, and you sit around just waiting for the patient to die and their heart to stop. When their heart stops, they have to be certified. And there's a long, warm ischemic time that the liver doesn't like. And then there's the storage time and then the transplant. And these are livers that we know in general have a higher risk of bile duct problems. And they're not something that we ideally would use in a PSC patient who's already got bile duct problems. So you can see that up till about 2016, there were very few DCD donors. This is our Victorian data. So most of them are going to be brain dead donors, but this has increased dramatically over the last 5 years and with COVID. So we're now looking at maybe up to half of our donors coming from patients who've died after a cardiac death, not after brain death. And this is the sort of problem you can get. This is a DCD donor, a 56-year-old PSC male. And within a few weeks of his transplant, you can see the bile ducts, instead of looking smooth, are looking very ratty and narrowed and dilated. And this is a couple of weeks after that. See the little narrowings and pinching off. And then at 14 months, major stricturing, dilatation, debris, infections, liver numbers all over the shop. And this patient required a repeat transplant a year or so after his original transplant. So we can do lots of fancy things, and this is what we can do. We can split the liver in two. We can give the big chunk to an adult. We can give a baby chunk to a baby. This is an adult my size could give this little chunk of liver from me to a 7-kilogram 1-year-old, and that's the liver divided in 2 bits. So that gives us enormous potential to actually transplant children. And it also gives us the ability to actually cut a liver in half in the donor. And this is a donor mother. And we're going to big chunk of liver here the size of a footy, but this little bit off the corner is going to go into a 1-year-old son. And that's the liver waiting to be partitioned. And you can see you have all these plumbing you have to take off, and then this little chunk is then stuck into the child. It's non-anatomical because all the plumbing is very different. So there are problems related to the anatomy that increase the risks for the recipient. And of course, the big risk to the donor is that they're having this major 8-hour operation. So this is a mother who donated to a 1-year-old son. So the mother herself, Dylan has had a 12-hour operation. The mother's had an 8-hour operation. And the big worry, of course, is that we will damage the mother. And around the world, there are a significant number of living donors who themselves have died or who've gone on to need a liver transplant due to complications. So it's a reason that we're not hugely enthusiastic about it. And our surgeons, when they tackle a living donor, are terribly nervous for the week or so of that operation. You have to be sure there's no conflict of interest. For example, parents will want to run into a burning building to save their child. All the parents volunteer and want to be a donor. But the mother may in fact have 3 other small children, and we're going to be risking her life, not just for him, but what about the other children? Coercion, donor risks, ability for donors to change their mind, and alternatives. So just about every pediatric transplant will work a parent up because they want to, but we usually can sit on the children, and the great majority of them, while we're waiting, can have an ordinary donor who's died. And there are ethics to organ donation. It's a public gift. There's debate about who owns the organs. Do we have the right to decide who should get transplanted? Across Australia, and with public involvement, we've elected to go for the sickest patient should get transplanted first. But even that's complicated because the sickest patient may have a very high risk of dying with a transplant. And the person immediately below might be a young mother who's still very sick, but actually has a better chance of surviving and has 3 other children. So this discussion and ethics around organ donation are really quite complex. One of the arguments is utility. You should give a donor liver to the person who's going to get the most use from it. So you just look at it and say, well, this person's going to have the chance of living the longest with that liver, so we should transplant that patient. And I'll just finish up a little bit about some machine perfusion. The livers at the moment just sit in an esky. We take them out, cool them, and sit them in an esky that we buy from Coles or Bunnings. And the liver doesn't like that. It can last 6 or 8 hours. So rather than that, we can hook it up to it's an experimental machine. It's a heart-lung machine, and the liver has blood supply. It's warm, it's pink, it's working, it's producing bile, and we can squirt drugs in. We can measure its function. And in fact, this is a liver. This has just gone onto the machine. We're about to take the clamps off. This is a fancy machine. It's going to pump blood into the liver. It's warm. And you can see very rapidly the liver starting to pink up. And there, an hour or 2 later, and you can see bile being produced through this tube. Well, you can almost talk yourself into it. And this liver is working, making bile, and we can measure lots of parameters on the computer to know that everything about this liver is working well. And we can maintain a liver on this for at least 24 hours and possibly longer, which has enormous benefits. And we can measure on the computer all sorts of parameters that tell us that this liver is functioning. I'll conclude with a picture to show what extraordinary treatment liver transplantation is. And it takes patients who otherwise have terrible quality of life and who really have very little time to live. And you can see a man here like this is looking at just probably a couple of months. And this is exactly 12 months after a liver transplant, his wife and 2 daughters. And this extraordinary operation, hopefully in the very near future, will not be needed. It's a very blunt hammer to take to an organ like the liver. But at the moment, it's still the only treatment we have if you develop end-stage liver disease. And it still remains an extraordinary treatment. And you can return to a very normal life. Not quite normal, but the great majority of our patients do extremely well. And it's something that at the moment is a potential treatment for anyone who may be running into trouble with it. So at that point, I've done a lot of talking. I'll stop. So thank you very much.